Ok, bây giờ vô chưa?
Vô rồi.
Ok, thì bây giờ trước kia cái lớp chút xíu khoảng xin Vân cho 10 phút đi
Ừ hứ.
để nói lại cái tóm tắt cái một bài kia. Tôi có coi vài cái clip của mấy bạn cái gửi lên trên mạng á, thì hình như vẫn còn chút xíu cần phải học hỏi chút xíu. Tại cái trình ca hay là nó gọi là presentation đó, nó hơi rất là đòi hỏi một thời gian mình mới quen, nếu là nói chuyện trước công chúng. Cái thứ hai, làm sao mình một khi mình đến cái trình độ là mình là bác sĩ rồi, đến một độ cao nữa như các anh chị là bác sĩ chuyên khoa nội trú gì đó, thì cái trình độ mà khi mà trình ca nó khác hẳn từ lớp học trò. Mà nó lớn, nó càng ngày nó càng, mình đi những cái conference nó thấy người ta trình bày những cái mình thấy mình hơi ngộp á. Nó rất là professional. Nhưng mà mình bây giờ mình đi học từ basic đi ha. Bây giờ mình có những cái gì đó, hai cái, một cái là oral presentation, tức là mình nói chuyện, như mình đi mình ca trong cái ví dụ giao ban, hay là mình đi trên giường bệnh gì đó mình nói chuyện thì nó ngắn gọn, mình không có đọc sách gì, mình chỉ nói thẳng là mình nhớ gì mình nói ra. Nhưng mà cái thứ hai á, là cách gì written, tức là khi mình những cái ca như grand round hay những cái họp mà lớn á, mà có màn hình này nọ, thì cái đó là presentation, nó dài hơn, nó càng khó khăn hơn. Nhưng mà oral presentation đó là nó more difficult because you have to remember and you have to be precise and have to be systematic, otherwise otherwise they will lost concentration. They don't know what you're talking about. You're jumping over all over the place. Then you will see look very unprofessional in front of people. Once you're up to the stage consultant, you need to present in precisely way, and people understand you, follow you. Even when the registrar level, they have to, when they present a case out, they need to tell us exactly sharp. We don't have a lot of time. They're good to tell us what we need to know. So I think I saw through three presentation on the web. I've seen a lot of improvement. I'm still a bit, I'm not talking about, to making diagnosis. It's still a bit, not sure, but presentation improving, but it's still lacking up systematically. And that's why you have a bit of a problem to put your thought into the presentation. So I'm going to give a, and Vân, give me allow me to give a slide, small, 10 minutes. I'll give you some basic presentation, and you need to follow this. Even though you're consultant, I'm a consultant, I'm still using this, like way how to present to my peers, to my colleague, even to my student. So first of all, you always know that, taking history, that I'm so strict of my medical student or with my registrar, that you need to know that systematic. Medicine is systematic. You don't learn systematic, you never get better. You have to stick in your mind the way, what we call template, the why you have to stick to that. You do it day in, day out. You go to talk to public, you never lose your confidence. So first of all, when your case, a couple of cases you present, you have to say, this patient, like 5-year-old boy has been, admitted in the hospital with, acute respiratory tract infection. That's what we call your presenting symptom. Why the patient here? That first and very simple, but very powerful for you to tell us exactly what the case starting. So next one, go history presenting illness, like, why the patient here, what they're presenting with. You like the case you present with asthma. It's something you have to say, this patient presenting with, like acute respiratory infection, get a shortness of breath, patient get a wheezy. They have to take the history and how long it has it for, and what anything on the associated symptom like coughing, vomiting. That's history presenting illness. I want to go one by one, and you see, why you're having difficult to put your, all your thing in presentation. So patient presentation, usually presentation, you have to, four things: history, physical examination. And most of the case you post, I think, are lacking examination. You got examination so important to make a diagnosis. Like just send me the message that, you know, most of the doctors in Vietnam jump straight to MRI, CT. I disagree with him, but I think it probably, you know, we've tried to stay away from those. And the test, you know, have to do the test. When you do a test, you need to know what is the test for and how you're interpreting the test result, not just order the test. And the next one is, you know, basic structure. You have to identify the complaint, the chief complaint, the information of what, and history presenting illness. Now, next, the important thing in the history presenting illness, when you're presenting something important, you're not just like, you know, something. I think the case presentation, your case, you all put in, you know, his or her father has asthma, so he got asthma. I think a bit slightly irrelevant, but not strongly relevant to the case. So social history, sometimes, you know, this is important. Some case, and this child, if the child live alone with his grandmother, important. Some information need to put in, some you don't need to put in. Now, the oral presentation had to be brief, about 5 minutes or less, or 3, 4. If you talk longer, then people will lack a concentration. They won't listen to you. It's so hard. People like men concentration only lasts for 5 minutes, maximum 5 minutes. After 5 minutes, you lose concentration. You won't follow the case. Should be the presentation should known by heart. You don't look in the screen. You don't look in your written, but you talk straight there. Okay, sometimes you look on the card, you know, when the registrar in doing the case in the ward round, or we go ward round, or, you know, we go through giường bệnh, then the registrar can look and just notes to look at the result. But sometimes you just talk like you get a chance to go with us to see how they're presenting to us. So again, I mentioned again, the oral presentation different, and written presentation much more deeper than oral presentation. So content should have to be 3 elements, have to be one single element. That's you do right. What the patient age, you know, the 5-year-old boy, that's one. The name of 3 or 4 active, this patient be admitted to hospital with acute respiratory tract infection, with coughing and fever for the last 3 days. So that 3 issue you're raising, that we know that, you know, some picture in our mind that what the problem is. And duration symptom, how long it has for you, that is very relevant, because if sometimes it can, you know, chronic cough, chronic asthma can last for a few years, or people get, you know, chest infection can be only last few days. So these 3 elements you have to present precisely when you open the sentence. You know, a 5-year-old boy presenting with, you know, chest with a respiratory tract infection, coughing, fever, lasting for last 5 days. That's it. That's all done for us. You know, we know that what it is. So like here's a couple of examples here. 72-year-old man transferred evaluation, blah blah, and 42-year-old with diabetic and a 3-day history. So that three elements we can give. We can have some information already in our mind. Like 59-year-old woman with prior diagnosis of breast cancer, rheumatoid arthritis, hypertension, referred 2 months of bilateral intermittent swelling. Look like, you know, get heart failure. See something there. So patient presenting, to go to history presenting illness. History presenting illness is fundamental oral presentation. That's the most important. I think the 3 presentations I read online, a majority we lack of this one. We didn't go through deep enough into this one. But we go straight into, you know, to other, you know, treatment, or it's too fast. You can't do it. So this one, 90% will give us the information already. So all the positive, we have to tell them. I think in your presentation, to give it too many negative things. Oh, this is chest clear. We want something positive. We know what's wrong. You might want to make a diagnosis. We don't want to exclude the diagnosis. We want to make a diagnosis. So, and also have to present in the order, time frame order, not jumping from one to another, not last month and this month and last month, okay? And also pay attention to detail. You think the important, like, you know, patient, the child present with, you know, like short of breath and couldn't wheezing, you know, you have to go detail in asthma. So if the current problem is direct attention on previous problem, and you have to, you know, this patient had this problem 3-4 years ago, and had been treated and how any complications. So this is something that if the link it in the past, you have to go through and go to give us some chronological order from how long has been for and how the treatment, how investigation come up so far. The next slide, I'll give you a negative statement is usually, we will love to use negative statement too often, especially when registrar, they usually give us, oh, negative. I don't want to know negative. I want to know positive. The negative statement included 3 category finding. Usually.
Sorry, are you showing the slide yet or no?
I didn't slide it. Can you see the slide?
No, we can see your main screen.
I don't know how to put the slide in. Sorry. Let's see. So far, I thought you've got a slide in there. No.
Yeah, because you.
I got a slide here. How can I get it in?
Yes, is it right now? Okay. It's a technical.
You can see slide now.
Yes. Now. Yes, now. Okay. So.
Oh no, I'm sorry. All right. Negative statement including. Can you see now?
Yeah.
All right. Negative statement included 3 criteria, 3 categories. So it's important to mention. If you need to mention, you mention these things. If the patient like the boys come in with your chest infection, you have the 3 important things. Yeah? When the boy had, have you say no fever, no sweat, no weight change. And the patient that you think of, like cancer, you say, no weight change, no poor appetite, no bowel habit change. So symptom relevant to organ symptom. If the patient comes with chest infection, you don't tell me what she got no abdominal pain. Something relevant to exactly what the patient presenting with. And also important risk factor. If the risk factor for the boy with the father had asthma, it's okay. But if the patient coming with like cardiac, heart, like myocardial infarction, then you said this patient had risk factors: smoking, obesity, diabetes, a past history of ischemic heart disease, or family history of heart disease. So that, or you said no, this negative, that's probably relevant. Or also any workup this patient has seen by anyone in the past. I know that in Vietnam, a problem with the information availability from one doctor to another. But once you work in other country, you need to know if it's vital important the patient got all the information in what they have been treated in the past. And also you talk about the patient transfer from hospital to a hospital. You need to know information from the other hospital. What have they done from before, prior to the baby being transferred to big hospital for abdominal mass. So another thing. So other and after you do history presenting illness, you go into any other medication, medical problem, medical surgical problem medication, and allergies. So that's the next one. And they go into detail this problem. You have to briefly mention what other medical problem, like his other problem, a 10-year history of diabetes with a retinopathy, neuropathy, and HbA1c. So this is some relevant information in other medical problems. Like especially when you do surgery, you have to know what the past medical history. If the patient has a like ischemic heart disease, I probably wouldn't prefer to operate on the patient. So physical examination, the next one, I got a few more slides. Physical examination important. Please concentrate physical examination. You need to at least you listen to baby, the boy or the daughter, the girl chest, whether any wheezy, any base air entry, where any percussion. You have to do all these things before you make a diagnosis the child had asthma. Everyone that got pneumonia, how do you find pneumonia? Pneumonia not just only by on the chest X-ray, but you do history and also the examination. You see, lung consolidation and base of the lung and air entry decreasing or percussion notes. So physical important, very important. So for important physical examination, you have to first of all have to be pleased. Remember, your consultant level is now hard, but if you're thinking about your trend, you do your work somewhere else, you have to go back to basics. And what I like to do, and you look from the top to the bottom. first starting, you know, all the vital sign. On the vital sign, what vital sign? Blood pressure, you know, heart rate, your respiratory rate, and you know, temperatures and all that. Then from top to bottom, remember, always don't miss that. I think, see, general description, the patient, you know, some, you know, case you present, the patient had, you know, the vascular thing, but something have to be, you know, precisely. See, like physical abrasion, blood pressure, and that's it. You go on, including all abnormal finding. Whatever you're finding, you see the patient really tachypnea. Is one of the cases when the boy had, you know, respiratory rate 54. It's a very highly, you know, like high rate. So you need to presenting it and all the what other finding. So that's next one. And complementary test is the one I really, you know, when I talk to the student in Saigon, they really, most of them jump straight to MRI. I just really don't like this. Complementary test, you think what the test will help you to come up with a diagnosis. Basically, you do right with the blood test, look at white cell count. What happened to peak flow? You know, you just a peak flow. If you think asthma, why don't you do peak flow? Peak flow at the table is so easy to do it. Just you can see it. You can do pre-Ventolin and post-Ventolin, you know, peak flow to test. So laboratory, you see, you know, oh, full blood count, you know, biopsy, and anything you think is relevant, but don't overuse, you know, the complementary test. And in all the tests, you need to know, you know, we have a system here. We can go on a computer and see what the past test, you know, result of the past. But some of your patients will be challenging because a lot of them don't have, you know, the test, you know, they had in the past, so you know, can't compare. So always, and secondly, I just remind you that a lot of, you know, when the student graduate for university, I used to tell them they have a license to kill. Because they start killing people. You know, you medical student, you don't kill people, but intern, a resident, first year, you start killing a lot of patients. Why? Because people don't read the result properly. They look just only the one have been highlighted, especially INA, looking for clotting, you know, result. It's very easy to kill patients. You need to look. Like if you look at the creatinine in a patient with the kidney, you know, in pregnancy are different, in elderly different, in your young one different. Always looking the result relevant to the clinical situation. Don't just look at the reference of the lab. The lab give you reference is all completely not related to your clinical at all. So assessment, and now you have to assessment. That's why differential diagnosis come in, and you do a treatment plan. Treatment plan that be precisely, you know, you have proved that a diagnosis right based on all the information you got. Now you provide a treatment. So when you present the treatment, they say, oh, this patient present with the asthma. We are done all the physical examination, this and history. Now we start treatment of patient with your Ventolin nebulizer and theophylline or other steroid, whatever you think is, you know, the right treatment. And if ask yourself when you present a case, what the principal and result issue is, you know, like diagnosis and a treatment. So, and also, you know, talking differential diagnosis, and if principal and so diagnosis assessment in three to five, most likely, not too many. Used to be 3 cases, 3 differential diagnosis. And what you tell I think most likely this patient had, you know, patient had asthma associating of, you know, like COPD. A patient had pneumonia, but I think most likely is asthma. And have to prove why the other one is not relevant, not important. So treatment, to choose the plan of treatment, then then you choose something, you know, this is a different one. So I don't need. So treatment, you have to provide a treatment and what your plan of treatment and how long the treatment is going to be last, and the what the follow-up is. So so what I think is just this very simple and brief presentation. But if your case, I might be do this way. The 5-year-old boy present to accident emergency in the hospital with history of 3 days unwell and just like difficult breathing. You can use dyspnea, but difficult with breathing and high fever. He was well before. He has no problem medical, have no medical and surgical history. But his parent noticed that 3 days ago he had become difficult breathing. He unwell. He not eating well, and he become progressively getting worse. And the father taken to the hospital. That's it. That the present some. You got he lived with his parents. He got no probably schooling normal. Then next thing, on examination, you see the boys, the heart rate was 54, quite fast. His temperature was 37 degree, and he looked quite unwell, and he he got a chest like breathing costal recession. You could say something else. On auscultation and chest were clear, whatever you mentioned clear, but there's some basal decrease in entry at the base, and all the examination, abdominal examination is normal, and heart rate is slightly past, but nothing else. Okay, then that's my impression or my differential diagnosis. The patient might have asthma, exacerbation of COPD, or patient has patient have the pneumonia. So what I'm going to do, this patient, I'm going to do full blood counts and check your white cell. Why you do a full blood count, and I do chest X-ray, and we do the diagnosis. If the proven to be just asthma, I'm going to give a Ventolin, and I'll do the pre and post Ventolin peak flow and the treatment. Then if the patient getting better, and we just get them plan a follow-up to give the parent information on how to prevent asthma attack. And for follow-up, we come back to see doctor in a few weeks to follow up, and using the medication as you described. So that's the way you're presenting in chronological order, systematically slide out, and everyone in audience, they will listen to you. They know that what you're talking about, and that symptomatic, that you know the topic. You don't just guessing and jumping around. I know that English is difficult for you because second language, but if you put everything in system, and you never get problem with it. That I teach a lot of foreign doctors, they have a problem exactly like your problem is starting with this. But they gradually, they take 6 months, they learn the basic thing, they go back, basically beautiful. They same at local, they present even better than local. So I thought this, you get some little bit overhead with what, you're starting with how to go through. Now I hand over to Anh Bấn, and we just see, we use a little bit of this one, and we see how we, go with the case today.
Hello, thank you very much, Anh Phú. Okay, before we go to the oral presentation that you practiced today, just tell me honestly, could anybody sum up what Dr. Phú said?
Actually, I just did. I put it in the chat box.
Okay, good. Okay, bravo, Sarah. Okay, now, I just asked you about listening comprehension. How many percent that you catch the idea from Dr. Phú? Say 10%, 20%, 50%, 100%. How many?
0%.
No, don't say so. No, I would like to test the level of listening.
I think it's quite difficult, especially in the first step, because we have no slide and different to follow the what he said. But when he show up the slide, it's more easy. So I think because the slide the Dr. Phú sent us already, so some of us to read it already. So in fact, I think it's just under 50% can listen to Dr. Fu, but we are maybe understand on of the slide because we read it already before. Thank you.
Good. Okay, so now let's jump to the practice, okay? And then we will go back again what Dr. Fuchs taught you, okay? So now, who is the first team to show us? Okay, you run the show now.
We do one by one, not a group.
Okay,
yeah.
So you just report by personal reports, huh? Okay.
Yes.
Yeah, go ahead.
Hello everyone. Let me introduce my case. A 37-month-old boy presented at PICU department with a chief complaint of fever and seizure. He was well until today with moderate fever, headache, and vomiting, less cough, interest drinking, and eating, no skin rash. He didn't drink other medication except acetaminophen and has no allergy before. On physical examination, his heart rate 140, respiration 25, temperature 39, oxygen saturation is more than 95%. The patient looks lethargy, irritability, hypertonia, and Glasgow from 10 to 11, stiffness and cognitive side positive. He had no more heart sound, capillary field, breath sound, and a soft abdomen. He has no rash. With complementary test, white blood cell 30,000, neutrophil about 73, procalcitonin 30 mg per milliliter, C-reactive protein 480, serum glucose 10, and with lumbar puncture, cerebrospinal fluid has leukocyte 40, neutrophil about 80%, glucose 0.2, protein 1.7, plenty positive, and after 2 days, culture of cerebrospinal fluid to find streptococcus pneumonia. We diagnose meningitis by streptococcus pneumonia with complication, severe sepsis, and coma. We just with support respiratory with intubation and given mechanical ventilation and infused antibiotics, vancomycin and meropenem, and dexamethasone. We use sedational drugs, phenobarbital and midazolam. After 3 days of treatment, he reduced temperature and alert we take antibiotics and continue antibiotics. That's all.
So now, the instructors, you have some idea, any comments about the report from the student, from the doctor of Đà Nẵng?
Yeah. Thank you.
Okay, you can mute your mic.
I will pass on this one. It's not my area of expertise, so I don't want to comment on something that I'm not too familiar with.
Okay. Dr. Như?
Yeah, I think the case present very well from the history. Just a little bit of the vaccine where I'm not sure that I catch the vaccine history in there. Social, I don't think that I catch anything for just history of allergy. I catch it. I don't see any allergy. History of 2 days of everything symptoms is very clear. The vital sign is clear. The symptom sign and symptom is clear. The labs, I will just suggest that if it's increasing or decreasing, you might need to mention, because sometimes the number is different, the unit is different, then we don't really grab it well on this one. The complication, the diagnosis is clear. The plan of treatment is clear. The course of illness is clear, but the prognosis and the follow-up, I'm not sure that I hear that one well. So that's only my my recommendation for that.
Okay, thank you, Dr. Như. Okay, before Dr. Phú give you some feedback, I would like to tell you my opinion. One, I'm not a specialist in this case, in a pediatric saddle, but I would like to tell you some of my opinion. This one is oral presentation or the presentation for the meeting?
Oral presentation.
Okay, so any oral presentation should be make a shorter, just about 5 minutes. Okay, you just lingering out and over 10 minutes, people get lost. Number one. Number two, you have to pinpoint which the most important, because you have some idea in your mind already about the diagnosis. So you have to guide the listener to listen that which one that you want to, okay? They will ask you, when they're not sure about that, they will ask you, but say that for example, that Dr. Như already tell you about the lab test results. You don't need to list so many things there. People just get lost. You have to pinpoint, okay? You have to emphasize which one is most important, okay? And now, so suppose that your last diagnosis is a meningitis. So did you check the neck of the patient?
After 3 days.
Yes. Okay, because I try to write down the notes for me, but I just get lost because you give so many information. Okay, when you flooding people, you bombard people with information. People just get lost. You have to pick up which one is the most important in your report to make it clear, the clear scenario, the clear picture of the people, okay? You may mislead the people, but at least the people, when listen to that, they will figure out which one that they will ask you. Otherwise, I have no idea, okay? That's it, that's my opinion. Okay, Dr. Phú, you have any feedback to them, to her?
Probably like they khuyên what's I might summarize the place.
Yes.
Khuyên, do you have any feedback?
Oh no, I think I think that like Dr. Din said, I think, yeah, shorter information and more focused, but it's just a condition I don't see a lot. So that's why I didn't want to comment too much on the, you know, the medical aspect of that. But I think you give a good systematic presentation, but a lot of information, like Dr. Din said, maybe just summarize or narrow it down to the area that is important to the case. Make it easier for the listener. I don't have any other comment.
I think it's a presentation quite, I like it. The presentation quite clear, speaking quite clear. You emphasize a few points, very clear. Again, just I agree with other, you know, doctors is when you present sometimes the result might be difficult. You might easy way, it's white cell count quite high. If sometimes the patient don't know, you don't need the millimeter, something we don't know what millimeter. You say white cell count is high, but normal range is like say white cell count is 20 and normal range is 10. That's it. That we know that exactly that's high. And CRP 451 normal range is 10. So we have the information straight away, you know, like the lumbar puncture show this glucose, what the normal range. Just very simple that we get the idea what the level, how high, what abnormal, and a treatment. And I think we leave it from a clinical treatment. But other thing, you know, like symptom history presenting illness, which might you to come with a conclusion that like few other things which are like photophobia, neck stiffness, you know, some sort of thing. I'll give you more information. The meningitis. Get you that's the relevant point. That's a clinical side and positive side. You need to tell. If you say that the patient have no photophobia or no, you know, neck stiffness, something we get a negative, you know, rule out, you know, help you with, you know, in terms of making diagnosis. Initially, when you're starting, I think maybe this boy have the epilepsy, something, or pneumonia, some other thing. But you got to give us some little way to get audience, attractive audience in that I want to present this case with meningitis, this the other side. I'm not going to miss that. And also rash, you see vascular rash on the finger, that's very important. You get this, you know, like septicemia from a streptococcus pneumonia just spreading all over, then get the patient, get amputation. A very important point, just few more points. You need to literally go back to see, practice this case again. What point I'm missing, or impress audience this way. And again, with another group, it just plays when you present the result, just relevant to say, oh, this 15 normal range 10. That's it. We know that high. That's it. All that. Millimeter, we don't know what millimeter is. Okay.
Okay. I would like to tell you something more, because the report is not only the science but the art. You have to filter the information to up to the level that make the people listen to understand what's going on, okay? And I just want to tell you too, you need at the end, you need to give the conclusion or give the facts that you think about which disease you think about. That is, you have to give the different diagnosis. Number one, okay, because after blah, 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 you tell you make a conclusion to tell about the main symptoms and sign and the main test result. You think, oh, I will think number one, this, number two, that, number three, that, like Dr. Fu said, yeah? And then, but I think because blah, 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 I don't think that one, I rule out that one, I rule out. And after that, you go to the main diagnosis that you think. Okay, don't jump right away into meningitis, because I listen, blah, 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 and then, oh, you say that, oh, I think meningitis. So make people, you know, just like a gap, you know, people don't know what's going on with your report. Okay, thanks.
Yeah, I think that I have a bunch of presentation we can imagine. For example, is the patient just come into the ER, just admit to the PICU. The patient has been there for a while, and then do a presentation, a case that has been there for some days. So if it is the case, then it will be okay. You summarize a little bit on the HBI, like a 37 months old boy admitted PICU 2 days ago with fever and seizure. he started only for 2 days with fever, seizure, and vomiting, thing like that. And the admission, the center has this and this. The lab, white blood cell was increasing at 30K with 73% neutrophil. And you get a little bit more lab in there, and then you summarize the culture, you summarize the situation, and then after that you need to jump on how the kid look like today after 3 days of treatment. Then after that you go to the plan. So it's really vary from the kid just admitted to the kid presentation for staying for some days already. So just maybe it's just more clear on that. I think that with this presentation, it's likely that the kid already stay for some days. So it need to be a little bit more on the current condition and your plan for future when you want to switch the kid from PQ to floor, or send the kid home, or follow up the kid outside. That's all.
Thank you, Dr. Yu. So don't be discouraged, okay? Because this is a practice. Take more time. Yeah, will show you skill how to report. Okay? It's an easy task. Okay, but it's a beginning. Okay, it's a beginning. So don't feel discouraged. You did a good job anyway. In general, very good one. Okay.
Thank you for.
Now you know how I pass on the title. Ông già khó tính định vâng nào.
No. No. Okay. Now the next one, please. Okay. Now the next one, just make experience from the previous one. Huh? Make it short, and you know which the most important. You have to tell us. Don't make us get lost. Yes, please.
Hello everyone. Now I will present one case for everyone. A 2 years old boy present to emergency department with vomit too many and intermittent progressive abdominal pain at the left ventricle about 2 hours ago. He has not fever, has not decay, then abdominal pain appear. His personal history, he has intersection 3 months ago. And now he only has vomit too many and intermittent progressive abdominal pain. So I examine for him, and I release him size apply in normal. He has no dehydration, but he abdominal pain are very so much. I release he has not McBurney negative, abdominal bone negative, and soft belly. I decided to him test, and I give him to do abdominal ultrasound, and I detected he was intersection, and I think I will bring him to operating room to remove intersection by gas. or if it's too many difficult, maybe I will just read for him. Okay. Thanks for your listening.
Yeah, that's all. Yeah. Okay. Before the other doctors ask you, okay, I just ask you something because I am too old. Sometimes I couldn't listen to you. Very good one. You say abdominal pain in which location?
At left ventricle.
Okay. Why abdominal pain in left ventricle?
It appear intermittent, intermittent and progressive abdominal pain.
Okay. In the American way, we divide the belly into 4 parts.
Yes.
Right? So where is a ventricle here? Yeah. So I don't make mistake. I listen and I write down the notes. It's a ventricle. So where is a ventricle here? For the belly.
Sorry. I can't understand what you say.
Okay. Now, what is the location of the pain in the abdominal pain? Where is the location? You say in the left ventricle. That's correct. The ventricle is in the heart.
Into 4 parts. Which part in the
Okay, I can understand.
Yes, please.
Yes.
Which one? Which location?
Ý của em á, là ở hổ đầu trái.
You have left lower, left upper, right lower, right upper. So which one? Because you check McBurney. Okay, I listen to you and check McBurney too. Huh? So why the patient have the pain in the left side and then you check on the right side too? Yeah, it's okay. But
I think I have to check McBurney because maybe appendicitis is not is not abnormal.
okay, right? You can check McBurney when you think about appendicitis. But I believe that you did. It's good to introduce it in your report in 3 minutes only. Okay, that's information there, but you have to filter that. You have to pick up. Okay, McBurney is no problem. No problem. You think about appendicitis. Why you put in the report? Okay, sorry about. Okay. And I heard that you say about abdominal about nearly 10 times. Okay, that's good too. Okay, but you have to concentrate. Okay, because if you show that abdominal pain, so you just go ahead around that pain, location, duration, radiation, what aggravated, what's relief. Okay, it's just like the old car you already learned. Eh? Don't jump. I think that you jump a lot, and then so you say it's not concentrate on your report. Okay, I'm not an expert. Okay, I don't have a lot of clinical experience now, but the report should be clean and shorter. Okay, bữa nay chắc hơn ông già khó tính của anh Quang rồi. Okay, but because I believe that I have you, because when I point out your mistake, learn more. Okay. Now, Dr. Như, Dr. Khuyến Đỗ. Okay, you have any ideas? Okay, just make her encourage. Okay.
Can I have a little bit of recommendation and idea? Compare with the first one, this one is harder for me to understand. I didn't get the whole picture well. I cannot guess after that how the kid look like, why you go straight to the ultrasound and go to OR or surgery. How the vital signs look like on the kid. How the kid look like in general. So I didn't see the general status in there. I heard the Mapone and then want something of the negative also, but I cannot catch that well. I hear a little bit history of hip interception at 3 months ago and no fever, now increasing vomiting and pain, starting I think two hours ago. So I think that is a little bit missing on the history, on the vital sign a little bit, to see how the general, you can picture the kid no more or no less dots on the picture, that the audience can imagine how the kid look like. And after that, on the abdominal ultrasound, you might need to, I think that you diagnose the kid already with interception, and then is it the barium should be adding, or the surgeon should be consulted before, or the kid will be moved straight to OR. So compared with the first one, I think that this one I'm not quite get the whole picture. That's my idea. Thank you.
Thank you so much.
Okay, Dr. Do.
Yeah, for me, I think for the first part, when you describe the belly pain, I think you can be a little bit more descriptive. Like Dr. Nguyen said, location, frequency, what bring it on, what bring it off. And the vomiting, you just said vomiting, but you should go into detail. Is it bloody vomiting? Is not bloody vomiting? Is it associated with diarrhea or anything other thing? I think initially when you present up to the physical exam, I get the sense that there's something wrong with the abdomen. But after when you present the labs and the test, I still don't know what do you do, or you just think this is gonna be the result of the lab. So I didn't get the sense that you did the X-ray or something and you didn't find anything, and then you want to do an ultrasound. But and then you said you're gonna take them to the OR. So maybe just say we did X-ray, we didn't find anything. Maybe if we find something on ultrasound or CT scan, then we can consult the surgeon, because before, I don't know, based on your presentation, I don't know if you did the ultrasound yet. And I've heard in your plan of going to the OR. So that's a little bit maybe clarifying that. If I find something really abnormal, I'll consult the surgeon, and then maybe OR is a possibility, or conservative management. But that was my sense.
Okay, I give you the trick. Okay, when you report a case, that is, you already know about that case, and you know about your diagnosis. You know about what you have to do. That's correct. It's not new to you. You already knew. You already know. But the problem is how you present it to the other one. So suppose, like, you drive a car into the city, okay? You know the destination. That's your destination. So you have to show the people on the car that where you go, your street. So every evidence you have to build around, you have to structure around the destination. That's it. Okay. People you may wrong. Okay, you may go to the wrong way, okay? But at least you protect your opinion. Okay, that's the way, okay? Okay, không biết nói. Okay, nào anh Phú, yes.
Cho nói tiếng Việt chút xíu nha. Bữa nay có đi coi ngày, bữa nay ra ngõ có coi ngày không? Bị máy chém, chém ngang, chém dọc, chém tùm hết rồi. Just kidding. I think probably again, presentation is not easy. So I think I would suggest maybe we're a bit harsh to you, a bit difficult to you. We want you to learn. Okay, we're not trying to intimidate you. I'm just thinking of today, the bad day for you. So when you go home tonight, just go rewritten the case again. and do some presentation and just send online and see what we see if you can then change. Something a bit information is so, I just like you guys to do systematic medicine. You can't do without system. You follow a system, you never go wrong. Okay, next time easy. Just thinking today a bit bad day, tomorrow will be better. Okay, just do it and send it to online. I'll give you some feedback in you know, not public, just personal for you. Okay.
Ok, anh Phú nói tiếng Việt thì tôi cũng nói tiếng Việt luôn ha. Em đừng có sợ đó ha. Tôi làm cái đó thật sự ra hồi xưa không vậy. Tôi học á, tôi thích ông thầy nào mà khó với mình nhất. Thầy khó với mình á, mình mới nhớ. Còn dễ quá, cái gì ok nha. Không học được gì hết á. Ok, good. Em làm good job. You did a good job. That's okay. Okay, next. Yeah. Okay, now anh Phú. Okay, please run the show for me, huh? If you want to do.
No. What? Sao vậy?
Không.
Boss, you're the boss. You're the boss.
No. You are.
Okay.
Okay, next one. Yes. Yeah. Go ahead.
Yes. Now I will talk about my case. Tom is a boy, 3 years old. He was brought to the hospital by his parents. He has high fever, about 39 and half in the afternoon. He used paracetamol, but it didn't matter. He has seizures before when he has fever about 39 degrees Celsius. After examining him, his vital signs in normal limit, except temperature. He don't vomit, don't diarrhea, don't cough, but has nose running, especially his right ear has fluid, look like pus, and he talked to me. He has ear pain, and he doesn't have ache. When I press in muscle it palm, he doesn't feel pain. After otoscope, I recognize his right tympanic membrane has perforated, and left one has bulged. With all symptoms, I diagnosed he has a severe acute otitis media, and I suggest with his parents he should admitted in the hospital. And after use paracetamol, amoxicillin with dose about 60 milligram per kilogram by oral, divided in three doses, about 48 hours, and clear his right ear with antibiotic fluid. He is better, so we will use amoxicillin about 10 days for him, because he has fever acute otitis media.
Good. Thank you.
Thank you.
Okay. I would like to ask you some questions before the other doctors say. Okay. Number one, you say that his vital signs in normal limit. That's correct?
Yes. Except temperature.
Oh yes. So it's not normal. It's not a normal. Okay. You say that. Okay. High fever. Okay. and the other one, the other vital sign is in normal range. It's much clearer. Okay, yeah. Number one. Number two, different diagnosis. Okay, you see that the patient have the fever. You see the eardrum is the hole there. Okay, and you have the fluid. Is a fluid there. So you jump right away. That is otitis media. Have you ever think the other one? Because never think one thing. Huh? In medicine, you have to think the options. We have to think many ways. So beside that, do you think the patient may have the other possible causes?
Different diagnosis.
Yes.
Some disease can be diagnosed, such as meningitis, mastoiditis.
Mastitis. Yes.
I don't think them because he doesn't have a he doesn't feel pain when I press in mastoid.
Good. Okay, so I didn't say that you're wrong, huh? But you have to follow An Phu's instruction. Huh? Every time even that the other one is not good, but you have to make a list, at least 3 possible diagnoses. Okay, because it expands your knowledge. Okay, don't jump right away into one. Never do that. Okay, and you just list from us like you already list for us. Okay, and you explain why number 2 is not. I don't think about number 2. Why I don't think number 3 is up. Okay, just do it automatically. That's good for you. Okay. Okay. Yeah. Mm-hmm. Now please the other doctors. Yeah.
Maybe I'll start first with this one. I think I want to start in the beginning with your history of present illness. I think you mentioned the diarrhea, the cough. That should be part of the. When you say fever, then you can say no diarrhea, no cough, no dysuria. You should not include that in the physical exam. Also, like when you said fever, mention the positive and the negative thing. Any other ear pain, difficulty hearing, ear discharge, you should mention that in the initial one. And then I didn't hear about any lab or chest x-ray. You might not need it, but I didn't hear about any, white blood cell count, blood culture for the fever. And then that is some of I really like your assessment and treatment plan. It's clear and it's thorough. I really like the treatment plan. Yeah.
Okay. Thank you.
Yeah, I agree with Anh Quyên là is a very good presentation. Switch a little bit, like Anh Quyên say, that's very good. A little bit more of the vaccine, the allergy history, because those meningitis and ear infection thing is really related to those vaccine, like Haemophilus or pneumococcus. Vaccine, how it looks. So is a vaccine up to date, vaccine not up to date, and allergy to medication. So why you choose amoxicillin? Because they're not allergy medication. So you need to mention about the allergy history. And the sick contact, you might need to add in, and examination, vital signs is normal except like a Dr. Nguyen say, vital sign is high fever and the other is normal. You might need to mention a little bit about heart and lungs, sounds clear, within normal limit exam, and then you jump to ENT, then throat check. Yeah, I think that's all. I think the other one is good. Yeah, I think that I don't have anything else to add. Very clear presentation. Thank you.
I leave the clinical decision making, and you try to follow the system, but you're still missing so many important points. But I try to correct your presentation. Try to use a bit more professional term. I would say, Thomas, a 5-year-old boy who presented the ER history of 3-day high fever, 39 degrees, and vomiting, diarrhea, whatever symptom you think. That's a symptom, bit more symptomatic. Like, just don't say he doesn't have the fever, he doesn't have vomiting. Some sort of precise in the way you do presentation, not just like talking this way, oral presentation. And what example you say on examination, each vital sign with a temperature 35, 39 degrees Celsius, which is quite high, and other vital signs, the heart rate, it should be, it's 39 degrees, vital sign should be heart rate, should be high. It can't be low because you could be tachycardia. So also it could be tachypnea, it could be fart, and that's other things. So if you think it's not right, you don't say that. Just, the vital sign normal, it can't be normal for 39 degrees. It's very high. And I'm just say on examination, this patient has the blah blah blah. You don't use he doesn't have something. Use something, on examination he has no sign of the tachypnea, then blah blah blah. Don't use so many lay words into the presentation. Sorry. Hello, I'll call you back. Hello, can you hang on the phone for a sec? Yeah, hi, sorry. Yeah. Right. There's only one follicle, isn't it? I think I can't do collection at Chennai at the Liverpool at the moment. I need to do in city because I don't have. Yeah. If you get Dr. Locke, do it for me. It will be great. Yeah. Sure. Okay. All right. Thank you. Bye. I'm sorry. Okay. Hospital call. So I mean, just go back to write the case in a way and send it to me and I can show you how to put a case in terms of less, talking presentation. This is more oral presentation, more professional way. But again, it's something 3 candidates so far lacking of system, how to follow the system. Then you're going to miss out a lot. Then you sound, present to us, we think, oops, but it takes time. Okay.
I like you most that you speak very clear, and I can catch everything you said. Okay, so it's good. Okay, keep it speak clear and with that pace. Okay, you have a very good one. You did the very terrific job. Okay.
Yeah.
Because some people they don't say clearly, so sometimes they said wrong. I couldn't catch it. Okay. Thanks. Okay, next one.
Hi everybody. Today I talk about sore throat case. Haley is a 6 years old girl with a 1 day's history of sore throat. She was in this usual side of health until 1 day prior to admission, when she developed the acute onset of moderately painful sore throat. And associated with the bands were febrile. There were no previous history of cough or congestion prior to cough. And the factor of her is she has a number of 6 contacts.
Her 8-year-old brother had a cold last week, and her pregnancy and delivery were unremarkable, and she was born full term and had no significant physical history. Her immunizations are up to date, and she on no medications. Had no allergy and has a rest on her appropriate development. On her examinations, she was not in respiratory distress, and her vital revealed normal blood pressure of 90/50, slight tachycardia of 110 ppm. Normal respiratory rate of 30, and oxygen saturation is 98%. And she fever with a temperature of 39 degrees. And she has swollen erythematous tonsil with exudate and painful cervical lymphadenopathy. On site and system, she will resent with in line with Streptococcus pharynx, and she was scheduled to have a throat swab. And after 2 days, the results show that her throat swab were positive of 34 group A Streptococcus, and so plan treatment for her is 10 days amoxicillin. Thank you for your listen. That's all.
So, can I have an idea? I think that the history very clear, a little bit extra on this case because this is a regular straightforward case. So you might need to just say that it's a 6-year-old girl we seen for 1 day of sore throat and fever, I think. Fever 1 day, something like that. She's in normal state until 1 day before, right? Yeah. Otherwise, she has no cough, no congestion prior. Vaccine is up to date. She was a healthy kid before full term, on full term. She's not in any medication and no allergy to any medication, right? And then exam, just get a quicker vital sign was fever, 38 degree, normal oxygen level, normal heart rate, normal respiratory rate. And then examination pertinent symptom will be the lymph node and the throat that you already described very good. You suggest the throat swab and it could turn out strep positive. You treat with amoxicillin. That's good. And you want to make sure that the how is it like a new patient? This is presenting a new patient, so that should be good in there. Differential diagnosis. If you think of something else, you might need to write in saying that also. Yeah, I think it should be fine. But if it's like longer, then you can do like a follow-up or something like that later.
Yeah.
Yes, in her.
I'm gonna go next if that's okay. Yeah, I really like your presentation. The history of present illness, I think so far is very concise. You talk about associated symptom and then also negative symptom of no cough, no congestion. and you mentioned sick contact. Those are a really good thing, and your exam is very focused and very nice. So I don't have any other comment. Maybe just to comment on, because some of the differential diagnosis for a sore throat could be, you know, viral upper respiratory tract infection or pneumonia. So just maybe mention like lung was clear, there's no crackle on the exam. But I think overall you did a very well job of the history in the exam.
Yeah, thank you.
I think initially I found it difficult to understand what you say. Maybe your voice is soft, but I think it's agree with other panelists. Is you're okay in a way. Case is quite simple case, but I with all the candidate, all the the doctors today, I like to say when you starting with I wouldn't say I'm talking today. You probably use your stand. I like to present a case today. That's the way how we use our representation, and I'm going to talk about it. You're not talking about, you present out the case to us. So I would like to present a case which is quite interesting. Whatever the 4-year-old boy presenting with 3-day history of fever and unwell. So that's the way how you starting sentence, and also using a bit more bit more facial expression a bit. You are very too tense. Bit relaxed and smile and give out some stop and start, something a bit more, get a more case more interesting, and be that a good one. It's easy case, but the way you present the vibe, but still missing feel bit and bit. There's always there in medicine. You always miss something. You never complete. But that's a good thing. Okay. Anh Vân chắc cái này happy anh Vân á. Okay.
Yeah. Okay.
Maybe one last thing on the couple of word pronunciation. I know you try, but the word is erythematous, exudate, and then lymphadenopathy, and then erythematous, and then exudate. Those are the words that I think you mispronounced, but we will be able to understand you.
Okay. So I myself, I have a hard time to understand her anyway. But thanks to Dr. Quyến and Dr. Như, I catch some of the principle that from her report, but maybe I'm different, okay, because something I would like to tell you that sometimes you have to use a little bit common terms rather than very academic term, because when you report, it looks like that you read it from textbook, but not from talking, okay. Something like, for example, like you said that prior to admission, you just say that before admission. It's easier for everybody. Right? You don't need to use a prior, okay? Or you say that respiratory distress. You just say that very hard in breathing. So it makes everybody understand, okay? Yeah, people still understand prior to admission and understand respiratory distress, but it is a little nicer. You speak at like very like talk rather than you read. That's the problem. Okay, thanks. Okay, anyway, good job. Okay, next. Okay, go ahead.
Good
morning. Today I will report a case. This is a 3-year-old boy. He presented to hospital after 4 days of waiting the bed at night. A few days ago, he was not eating well, and most of the time only wanted to drink. Before bed, waiting at night, he was using the bathroom often during the day, and he seemed thinner than when he was 2 years ago. Examination shows that he activity, he no fever, stomach ache a bit, but no vomiting and no diarrhea. he urinate a lot of times. There's no pain when he urinate, and his urine is clear. He no use any medication. About history, he know only risk for medication and food. In his family, no one have a disease. And my result of test and about your urinary test, red blood cell and leukocyte were normal. But the glucose level it had were over 500 milligram percent, and nitric and ketone were negative. About blood sugar test were 400 milligram percent at the first time, and 450 milligram percent at the second time. About HbA1c is 7.2%, and diagnosis of type 1 diabetes mellitus. And now he treatment with injection insulin. Now this is double rapid 3 times a day before meal, 30 minutes, and lunch stop at 9 o'clock p.m. and to be monitored by dietitian before its injection insulin. That's all.
Okay.
That's all.
Okay. Thank you. Okay. So your reports are very in detail and tell us a lot of information about that. But from the information that you gave us to the conclusion, I don't see the gap between. I don't see the gap. Okay. Because here you may talk about the patient have the diabetic. Okay, Dr. Như will be an expert about that. I don't know about diabetic in children, because you say that A1C is 7.5, and then you think about insulin. So I catch from those information, and I guess that your diagnosis is a diabetic, maybe type 1, type 2. I'm not sure too. Okay, but I really don't connect between your information you gave me and the diagnosis, and the possibility of differential diagnosis too. Okay, this is my ideas. Okay, now, okay, the other doctors.
Maybe I'll go first, because I don't know much about this either. But I think what I remember from adult diabetic is that you describe a lot of like increased thirst, polyuria, weight loss, excessive hunger. And I think all the symptoms you described are pretty on board with that. And I don't know if it's different for you guys, but I've noticed all of you guys mentioned vomiting, diarrhea, clear urine after you mentioned the vital signs. So I don't know if it's different in pediatrics, but when we go to vital sign, we just go to the physical exam. So after you go to vital sign, everything should be about the physical exam and not the review system anymore. But I think it's a difficult case to present, because they don't have a lot of specific symptom on exam or based on the history. But I think overall I was able to understand that, looking back after you told us a diagnosis, now I can see the relevance of all the detail that you mentioned at the beginning. That's it. That's all I have.
Okay, Dr. Như, you are an expert. Okay, maybe I will listen to you.
No, I sent to endocrinologist. So it's a little bit different here. Right? I sent to a hospital. Okay. Can you repeat the first? I get lost at the. I know that the urine have glucose is normal, nitrate is normal, ketone is normal, but something about first and second. Can you repeat the result?
Blood sugar, glucose serum. Get in the
okay.
The first time is 400 kilogram percent, and the second is 415 milligram percent.
Oh, okay, okay. So how do you come up with the type 1? How you come up with a type 1 insulin? I know this is diabetes, but how you come up with a type 1?
Because he have a problem with urinary glucose level. So I just some test with blood sugar.
I think the diagnosis is the diabetes mellitus, but I'm not sure the diagnosis of the type 1 is it based on only this. First thing, yeah, that's right. It's not always type 1 in children, mostly like type 1. So you need to be more on the either exam or lab. Insulin ketone normally is a little bit positive. It's not always negative. It's nice to be negative. So it's not a ketoacidosis kit. Might need to do the pH and make sure that it's not an acidosis kit also before you jump into the treatment. So and then might need to consult also endocrinologist, and the way you put treatment is good, and then you might need to make sure that the kid is instructed how to eat in a certain way that helping with the insulin. Make sure that the parent know everything about this one before you send the kid home, and when they need to come back to see you. So anything else I'm missing? It's good that you do the exam in there. Might need to do a little bit more about all the general status. For example, the kid is alert, active or not. Any other tummy hurt, because those one can relate it to ketoacidosis in there. So a little bit more detail on the exam and on the history. So I would say. I think that you also mentioned about the urine like this to make sure that you differentiate with the UTI, I think, the way that you present the case. Anything else? Yeah, basically you need to make sure that you diagnose the diabetes, and then how you diagnose the type 1. Is there any complication for the diabetes happen right now that you need to present the case, that so the other people know that what you are dealing with, like a ketoacidosis, you might need to do differently, admit to the PQ and do some more treatment on that acutely. So, but so far with this one, I don't see any ketoacidosis in there. Thank you.
Thank you.
Okay. That's when you introduce at the beginning of your report, you say that the patient have the wetting bag, correct? First sign that's correct. FTP in the bag, that's correct. Yeah. Okay. I'm not sure 100%, but because a little bit misled me. Because first when I think of that, is maybe that baby or that child have some kind of psychological thing. Yeah. So but it's good too, because I'm not sure about Dr. Nguyen, but I think that diabetic in children, sometimes they detect it accidentally or by the blood test, by the blood sugar test, okay? Because it's very vague symptoms there. So sometimes people didn't expect that happen, okay? But through the test, luckily that we guide us to that diagnosis. So that's good too. The other one, I think that is okay. I just want to say one thing I would like to tell you too, okay? You can say that urinate. That's fine. There's no problem. But in talking language, you just say the P, avoiding or something. It's easier for everybody because you just repeat it and you not pronounce correctly. Urinate, urinating, urinated, or something like that. So sometimes just say the very common term. The baby or the child pee or void, or something like that. Okay. Yeah. Thanks.
Thank you.
Anyway,
I got to add on this one. When you're starting first, I thought the kids might get, UTI. I think, first impression, I thought the kids might have, urinary tract infection. Because bedwetting might lead us to different, the diagnosis. But I think many on the presentation, when you're presenting, I have to say, if you said he came from family history, there are no no history. See, medical surgical history, there knows, past medical surgical history. It makes it easy because the template you go through that you have to go use other thing to describing it. And also making diagnosis of diabetic, in children is very, very important. It's affecting the kid's life. You have to make sure that you make a right, diagnosis. When you give us the level of the blood sugar level, you have to, just some again, you like the other one, you give us a number and we don't know what number. Sometimes you use different, your lab level, and we use different lab level, you might see the level was 419, the normal level was something, and we know that the level is high. So you give a millimeter, sometimes we have no idea what millimeter thing, or milligram thing, just please again, just whatever, to give us the reference range so we can understand what you're talking about. And it's HbA1c, of course, 7, we know that high, but making diagnosis of, could be that type 1, could be quite too hastily, too quick. If I was here, the kids might present, I have to consult endocrinologist to make decision. That you have someone else to help us to make a diagnosis. And also, lastly, you did not provide any follow-up, any plan of long-term measure. This is lifelong for the kids. You give us some formula, how you approach it for long-term education, diet and dietitian, and all the endocrinologist to follow up. It's a very big case. It's a very big. They will not assess you making diagnosis. We assess your competent how you manage case for the long term. And another thing with ketoacidosis, I'm just not sure why keto normal. This one a little bit I hesitate on the test result here. And lastly, when you get in conclusion, you summarize the case in summary, and you don't say, you must have just said that's all. That's not professional. We don't present the case when you tell the audience that's all. It's that in conclusion, and this patient had it. Or thank you for listening. That's it. Not all. They're not that's all. And then we know the case had been ended. Okay. Thank you.
Thank you.
Okay. Before we step into the other one, I would like to tell you about the unit of blood sugar, because in Vietnam, in North America, we use a different system, different units. So I give you the cue, because in Vietnam, you measure by milligram per 100 mils. It is milligram percent that you already told me, 400 milligram percent. In the US, in Canada, and maybe in Australia too, we use millimole per liter. So it's very hard, like Celsius and Fahrenheit. So it takes time for me to switch back and forth. Okay, so I give you the cue. His magic number is 18. Okay. If you use Vietnamese system, you just divide by 18 and you go to the international unit. And the international unit, you just multiply by 18 and you go to the Vietnamese one or maybe the American one. Okay. So remember here, because I'm not sure when you meet with the other, like your colleague from different countries, they may use different unit. So 18 is a magic number here. Okay.
Thank you.
Okay, next. Good. Okay. Go ahead.
Okay. I will introduce my presentation. A 9-year-old girl admitted to the emergency department with chief complaint of vaginal bleeding and many bruises in her body. The next door neighbor found her at home 2 hours ago, and she told us she was attacked by a friend of his father. At that time, the girl is alert, anxiety, and crying. The vital sign, the heart rate is 120 beats per minute, a little tachypedia, and other vital signs is normal. There are normal heart sound and lung sound. An exam of her body, there were a lot of new white marks and bruises in the shoulder, the neck, the breast, and she has no abdominal pain and no abdominal reflection. The genital examination found that the swelling of the labia majora and the imperforated human, the aneurysm. He has been taken the sample of STD screening, HIV screening, and the diagnosis of and the history of hers is no get the period, yes, and has done the SPV vaccination. She is a stepchild who lives with his father, who is alcoholism. And the diagnosis is child sexual abuse. The treatment is clean the tissue damage and do and waiting for the result of the SID test. And we have the plan for the psychiatrist to help her in the mental problem. So in conclusion, the 9-year-old girl with diagnosis of child sexual abuse and no findings of no have any finding of the STI inflammation. Thank you for listening.
That's a hard case.
That's one case.
I hope it's not a real case, but
Is it the real case?
It's so difficult for me.
I think I gave you the topic about child sex abuse because we know it's not uncommon in Vietnam at all, but unreported. So I love that you talk up this case and raise the issue, and we could learn. All of us can learn from this, and especially all the doctors in Vietnam can learn, and from this case. So a few things I'd like to mention. This one. the way you test STI and you know for the chlamydia, gonorrhea, HPV, HIV, and also you need to do follow-up test HIV, not HC and hepatitis B and C. We have to repeat the test in 3 months to say, you know, seroconversion, not just only one test.
Yes.
And examination, I think you probably have to say you do examination in very, you know, that quiet environment with, you know, with supporting people, and in particular the trauma, psychological trauma impact for the whole life. Then and with the long-term management, not psychiatrists. I think a bit too hard for the kid in psychiatrists. You don't send psychiatrist to see this baby, little girl been affected by been sex abuse. So psychological, you know, support, and also the social support is important. Not psychiatrists. Psychiatrists put the kids in the mental. These kids had no mental problem. These have been, you know, perpetrated problem. So we need to get a social, and probably not sure how the system in Vietnam, but in here we got Department of Human Services, so they will step in to take all investigation and prosecute the perpetrator. And also we provide long-term, you know, social support for this kid, you know, being really disciplined, long-term, you know, scar for this young girl, and a lot of work on this girl. So I think we in Vietnam might have to make a, you know, step to introduce some system to support the, you know, the child, rather than, you know, I've seen a lot of report in the news and all perpetrator being got away from all this, and the child become a victim rather, you know, perpetrator is a victim. And I think I'll leave it for, I think we've seen quite a few, we all mandatory for, we ask for training to cope with all the, you know, child abuse, and also we've been screening for all, you know, screen the child protection here. So we have more knowledge in terms of management. This is a very big, quite high prevalent in Vietnam, but unreported. Thanks.
I would like you to tell me about my presentation, Dr. Phu. Is this the presentation suitable on the coronary attack? Or is this okay?
Now I go first before Dr. Phu. Okay, your presentation is very clear, very easy to understand, but it's too clear. Okay, because you and people catch right away. But it's good. That's okay. But in reality, never we have some report like that. Huh? Your report is completed, and we catch right away at the half of the report. But that's fine. You report very clear one. Just one pronunciation, okay, like in full, ask you every medical term. Sometimes you have to Google that and you pronounce correctly, okay, like hymen, yeah? It's not hymen, okay? So these are a very important one, okay? So you have to pronounce correctly, yeah? I and E usually we do make a good confusion here, okay?
Hymen, yes.
Yeah. Hymen, not hymen. Okay.
Oh,
you say hymen, eh? That's correct.
I say hymen, and I have to look up the dictionary, and it's
say hymen.
No, it's not say hymen. Maybe it's a kind of the consonant that I misunderstand. It's say.
Okay. Now just check again. Okay, maybe I'm wrong, but yeah. I listen to you. I hear hymen. Okay, but it's a record already here. We can check it. But that's fine. It's a minor one. I don't say particular terms, but any medical term you're not sure, you have to check it to make sure it's good. Okay, some medical terms they can pronounce different one. Okay, it's something like intestine and intestine. Yeah, something like that. It's okay, but sometimes you should check it to make sure. Okay. But anyway, your report very clear. Okay. Yeah. Any other feedback before we move on to the
for me, just a brief one. I think you did a very, very good job with a very, very difficult topic. But I don't know, in the US, in this situation, you have to report to the police and also to the Child Protection Service, so the child does not go back to the same home that it was abused in. So I don't know, that is definitely part of your presentation, that you have to write that in your note, that you contact the Child Protection Service so they can help protect this child from that person. But I don't know if it's the same in Vietnam or how does it work, but those are the two things that you have to report. It's a criminal. Yeah.
I'm curious, in Vietnam, we have just some similar agency like that? Is to protect the child, to protect the children?
Dr. T?
Normally the family member will note it with the police, and after that the police will go to the hospital, and we have some discussion about how much damage on the patient, and we will invite another person from the candidate with a doctor specialist on the gọi là bác sĩ pháp y. Yeah. We have a conclusion after that.
But after you have the conclusion, where the child can go?
Go home and live a normal. No have any police protection for.
No, at least a social worker or something, or some shelter, or somewhere to go, or they just send the child back to
send the child back home.
And the family again. And
Yeah.
after that, we transfer to
Too bad, huh? Too bad, too sad. Okay, that's a social issue anyway. Okay, now go ahead. Okay, thank you very much. Next.
I'll add on one more little one. You know, what you do have to do the swab. I think it's probably long if you want to present a case to the, you know, to not in Vietnam, you have to do the swab for DNA testing, and we kept it for record later for prosecution. For like the vagina swab DNA.
Có lấy ADN của cái đó là bác sĩ pháp y hả? How to call a pháp y doctor?
It might take a month to come in. All evidence been washed away. So I think what you do, you have to do the swab. And what we do here, we do in, you know, when examine a child, we have to do the swab. We took it, you know, evidence the swab, and with 2 people, and we recorded that for future prosecution. Not we were waiting for the other guy, the evidence will be gone.
The swab will be done by the psychologist.
Okay.
Yes.
Okay, what is the name of English for pháp y?
Yes.
Forensic.
Okay, good. Okay, I don't ask you, Dr. Như, I just ask.
I'm sorry.
Okay, okay, that's fine. Okay, you know right away. I don't ask you. Okay.
I'm sorry.
Okay, that's okay. Now next.
Hi everyone. Today I'd like to present an interesting case. Jim is a 2-year-old boy brought into clinics by his mother, who noticed him with a pilot. His medical and family histories are unremarkable. He was in his state of normal health until 2 months prior to admission. He was developed the onset of palors, especially of the face. Associated with the palors was increase of tears and bruising. 1 month prior to admissions, he was taken to a local clinic, and without other testing, diagnosis was iron deficiency anemia, and described a lack of iron tablets. But the size of tires are increasing. He is no longer enjoy playing. He has no other health problem. He goes on immunizations and has no allergies. Doctor appointment shows he has conjunctivitis, bruising on the trunk and extremity, liver 4 centimeters below cotals, Morgan in midline, some notch lymph in neck regions. The vital sign was normal, and the total blood count was drawn that show the white blood cell 12,000. The hemoglobin was 65, the NCV 90, and the platelets 25,000, and presents a blood cell. The present main problem is anemia, and the possible diagnosis include thalassemia, iron deficiency anemia, but the diagnosis of blood cancers appear to be the more likely because he has normocytic anemia, no response to iron supplements, and the presence of blood cells. To confirm the diagnosis, he should be done some tests like bone marrow biopsy, and she should be referred to a pediatric oncology to prepare a treatment plan in more details. That's my presentation. Thanks for your listening.
Thank you. Okay, so I think that maybe I asked Dr. Yu, she have more knowledge than all of us.
Yeah, I think that is a very interesting case, straightforward, because at first they already have a 2-year-old boy with anemia symptoms and bruising symptoms. So they have two system, two cells line symptoms. One is for the red blood cell, one is for the platelet or something else like that. So, and then you present on the medical history of family is very good. The history of treatment also good, although it's not it's wrong thing to do, but at least we know that it's not, it's not wrong for you, but it's the wrong diagnosis at that time. So that's good to mention about that also. And no allergy to any medication. And you might need also to know that he's not on any medication, because some medication might get some side effect of changing the state of the kid. Examination, I think vital signs should be changing on this case. You might need to, heart rate again change, blood pressure might be changing also a little bit. General status, I think you mentioned very well. Examination, everything looks very suitable for a case of the leukemia. And then go down to the blast and testing. Everything looks very perfect. Differential diagnosis, you might be to do it before you do any lab. And then after that, you show up the lab, and then it's already have a definitive diagnosis already. And then you jump up to the testing and refer oncologist. That's very, very perfect. I like the case. Does it help?
Thanks. Would I ask you a question, two questions here? How about the patient liver and spleen? Have you reported in your report, in your oral presentation? Did you check the liver and spleen?
Sorry,
in your oral presentation,
yeah.
Did you tell anything about liver and spleen?
I just tell the liver is 4 centimeters below the costal margins at the midline.
Costal margin. Yes.
Yeah.
And how about the spleen?
And the spleen is no paintable.
Mm-hmm. So it's a little bit weird here, huh? Okay. Number 2. With your presentation at the beginning, you say right away about family history. That make me surprised a little bit, huh? Because in order, huh? Usually, because you say that, I think right away, oh, something related to genetic or something there, okay? So usually that, in my opinion, huh? We put the family history after that, not in before. Huh? It's a little bit weird to me because it's not logically in oral presentation, to my opinion.
Yes.
Yes, Queen? Yeah, Dr. Queen?
I think I just want to clarify your point. If it's a cancer diagnosis, I think family history you can present in the history of present illness, right, Dr. Din?
Yeah.
Yeah.
Yes.
But I just have one thing. The word is biopsy, not biopsy. That's other than that, I really like your differential diagnosis. That's perfect. You named three. Like your patient came in with anemia, and you came up with 3 differential diagnoses, and you say, why is the cancer more likely? Why is the iron deficiency not likely? That is a perfect way to present a differential diagnosis. I think that was the strongest point for me of the presentation.
Hi. Hello.
I think again, a little bit more systematic differential diagnosis first, then you use investigation to prove to make the right diagnosis, which one is which. And another one, I just remind you, when you give me the number, like platelet 25,000, I probably don't know what it is. So can you give me just next time, just when you present, to give the, what the normal range is. Then so we can get an idea. White cell count, maybe 17,000, 20,000, we might know something, but like they say, MCV 90 something, we're not sure what, sometimes we in our head, we don't know what it is. So give us somewhere the normal range is, or see, you can say, it's very high for the normal range. So we know it's high. But a good presentation, well done and good. And you refer to, pediatric oncology, that's good. Don't take it in, because everyone have, in America or what we, and the way we practice, we all subspecialize. We specialize in one field. We never take one in, something we need to refer on, don't hold on the patient. That's a good thing in management. And sometimes, if you know my student got an exam, I will ask you, what would the pediatric oncologist would do? That's the next step. That you need, if you send a patient to see pediatric oncologist, you need to know what that doctor will do for the child. Then you tell the patient, you make sure all the, let them know the other specialist will do. Then you have to give a bit more, pediatric oncologist will repeat the test, you will make a diagnosis of leukemia, and the plan of treatment depend what type of leukemia, then we'll treat, blah, blah. So give some sort of information for the parents before you send off to see someone else. But that's good, well done.
Yeah, I think that I'm sorry. I think I would like you to keep this case and make it into a consultation to the hematologist, oncologist later. So you can present the case, but with consultation into a specialist field. I think it's a very good detailed case for you. So for example, you already have that, and then you need to either call or send the kit to the oncologist. Normally with this case, in here, we will send to ER because of the hemoglobin and everything, and need to be activate him soon, not just like send to clinic. The clinic, if the kid was so pale, we send to ER, or we get the lab, and after the lab have done, we know that it's low like that, we send to ER, and then the ER doctor will call hematologist on call to consult the case. So they won't see the patient right away, but they will talk on the phone and to make sure that what they need to do right away for the kid to be stable. And for example, you don't want to transfuse the kid before they get all the tests done. So you might need to make this case into a consultation to the specialist later. Thank you.
Thank
Thank
you.
you. Yeah, thank you, Dr. Như. Okay, you good. Anyway, and a lot of improvement since the beginning, yeah? Mostly because you have to give different diagnosis, okay? But you know, we just turn up, okay? More and more precise, okay? Okay, now how many people more that we have to do?
Bác sĩ
Okay.
Thúy lên đi, bác sĩ Thúy lên ngồi. Máy chém, Linh máy chém đi.
No, anh Phú nói vậy là nghe ghê quá.
Anh quay em à.
Okay. Okay. Yeah. Ready?
I'm so sorry because I will find the presentation. Yes, the presentation because I don't remember, too old to remember everything. Ở đâu rồi ta? This is the presentation of An. Yesterday I helped her to do that, but I don't know where exactly. Giờ không nhớ nó nằm ở đâu. Hey, about boy hả? Hôm qua nó nằm đây. Phú này mày, Phú ghê á. Sao đây không thấy đây tay? Đây nè, đây đúng không?
Anh Vân dớt liền Vân.
Yes, I'm already. And hello everybody. Today I would like to present the oral care presentation. The name of the patient is Nguyễn Thị Ai. She's is 5 months, and she was transferred to our hospital because he has a mass in abdomen. And 3 days ago, she had fever, and her parents noticed that her belly seemed to be larger, more than normal. And the parent just gave her acetaminophen, and after 3 days, she recovered, but her belly seemed still larger. And she so worried and took her to private clinic to check. And doctor in clinic did an echo and saw mass in her abdomen. So that's why she was transferred to our hospital. About the maternal and disease history, his mother is carrying B hepatitis. So that's why he was vaccinated and took an antibody right after birth. And now this is the my symptom. She seemed normal development, and in the general, she have no fever, no child, no cyst, no fatigue, and no jaundice, no change in color of the stool or urine, and other symptom is normal, and the vital sign is a normal range. In the physical exam, there is a mass in her belt from right costal margin around 3 centimeters under the costal margin. The surface of a mass is not so smooth and cannot move in when we touch. And it seems no pain because when we touch, sees no feel pain or reaction. and I find that no rash on his skin. So in conclusion, 5-month male go with abdomen mass and no other symptom, no vomiting, no jaundice, and no change color in urine or stool. And other side is normal range. And so with the edge of her and the mass in her abdomen, my initial diagnosis is there is two sides behind peritoneal membrane or inside abdomen. But about the character, we think about the two group with a benign or group 2E malignant. Benign is sometimes she get a hemangioma or polycystic in kidney or bile duct. About the malignant, with her age, normally with womb tumor, neuroblastoma or hematoblastoma, with some initial diagnosis. So we will have some lab for her for blood counter, CMP, for example, the bilirubin protein, AAT, FET, all of that about the complete metabolite and kernel. And I will do an echo again to figure out what is the size exactly of the mass. And after that, when I think on of the result of this test will be resent us tomorrow, and at that time we will get another presentation and we will discuss further about her. Thank you for your listener, and please give me some advice about the left or imaging we will do for the patient. Thank you. Complete metallurgic panel.
Good, very good. Okay, your report is very clear, well structured, and you concentrate on the real problem of the patient, that is the mass on the right coastal margin. That's good. One thing I would like you to more in detail, that is you have to make a list of diagnosis neatly, okay? First one, you have to confirm that with the liver or maybe the kidney, womb tumors or something. Or after that, if you say about the liver, so what possibility of the disease of the liver, and you rule out one by one, okay? Because otherwise, I still feel that you still jump into right away. Huh? If you say about tumor, malignant tumor, benign tumor, so how hepatitis, how about abscess, how about something else? I know because you already make a physical examination, it's no pain, okay, smooth and not moving, okay, so you have some idea. But however, you still have to list the possibility of the causes, okay? Okay, the other doctors, okay, my knowledge is very limited, so maybe Dr. Quyên and Dr. Như and Phu, okay, they have more knowledgeable than me, okay?
I don't have any comment on this case. I think you did a good job. Maybe you can teach me how to present some case like this.
It's a compliment.
So,
yes?
Go ahead.
I think that you touched almost everything of the case of the mass. Maybe a little bit more on the history of the pregnancy and delivery. Any complication is a full-term kid or preterm. Any complication from birth until now or chronic disease. I don't think that I heard that. It's very good that the normal development, mother carrier vaccine is there. Any symptoms from birth until now that they noticed, sickness, major sickness. Vital signs is good. How about the appearance? Alert, active, or lethargy? How the kid look like in there? Any other symptoms for lungs and heart? Might need to mention a little bit on there because that is a big case. In the abdomen mass, it can affect the other area of the chest, rib cage. The diagnosis is the mass. Yeah, I think that Dr. Nguyen already say anything else beside the mass that you think of. And then the test might need including more than this because in the area, I think that is the costal margin. I think the left or the right side, either one. You have a kidney in there, so you might need to throw in the urine in there. And the ultrasound, you put it in already. The blood test to make sure that CBC is there, make sure they have no anemia. So those regular screening lab might need to be there also. Yeah, I think that's it. Thank you.
Thank you. Yeah.
I think everyone's scared the boss. That's okay. But I probably after this case, I'm run away from from this. I'm sure I'll be safe. First of all, the case you said the mother had hepatitis B and the kids had vaccination antibiotic. I'm not sure whether I was wrong. I listened wrong. I think probably I thought you mentioned your immunoglobulin, and hepatitis vaccination. Now we go to the case where skipping all the history thing. When I mentioned when it's probably a little part of the learning thing. When you do the math, when you do examination on the math anywhere, you need to for size, shape, soft or hard or surrounding. So need the size, the shape, whether the contour, rough, smooth, and it could, you probably use the word not movable, not mobile. Not mobile, I mean not moving. You don't have to, I can't move it. It's something you use more professional term. It's not mobile, and surrounding any structure surrounding it. So say anything other related mass surrounding that mass. Then when you do abdomen, you haven't finish the abdomen examination. You have to see whether either you got any ascites. Important because you know it from liver mass ascites. You have to do percussion to see any ascites, any shifting donors. You're looking for your Murphy side, where could be gallbladder, but very unlikely gallbladder. Sorry. Okay, fine. So is there any, and also, any like rebound tenderness? There are many things can do. Just I get into the good habit that if I do abdominal examination, I have to do these things. That's it, all in your mind. Then formulate the differential diagnosis needs to be clear. You said, this is the mass I found, in the costal margin. Could be benign or malignant. And benign are these, blah, 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 or malignant, these. We need to do more investigation to do it. Most likely you need to do ultrasound. But when you do ultrasound, if you want to talk to the audience, what do you think the ultrasound would pick up? What ultrasound finding would be? And how you interpreting the ultrasound report? What I'm going to organize ultrasound, see to check beside the mass, whether solid, cystic, or complex, any surrounding structure, any ascites, any Doppler blood flow would indicate malignancy. Or you do CT scan, whatever, like so blood test. But I think in a general something, it's more into what the case, big case. But if you need to do some workup before you go to next, tomorrow department meeting. You have to do all investigation or everything you got on your plate. Tomorrow you got the meeting, say, okay, this is a case, we got this, what you're gonna do, and everyone will go in. Rather, we have to go back do the test this, test that, and you can do tumor marker. You think, if you worry the malignancy. So many things can do for this case, and before you go into tumor, what we call the tumor, tumor board meeting, and then we decide what to do next one.
Thank you, anh Phú. Okay. I think it's a good one. It's improved. It's a lot improving. Okay, so but you just learn from, you know, we learn from mistake. Yeah? We don't learn from praise. Yeah? We learn from mistakes. So the more mistake you do, the more you learn. Okay. But anyway, this presentation is very concise and focus on the problem rather than jump one point to another one and user's point. Okay. How many people more?
Today we have 7.
Yeah.
We have just only very 8 members today because for 3 people on duty and 2 people because Storm and they just.
Okay, lucky for us too because I am so sleepy now.
Thank you so much. Everybody.
So what's the plan for next week?
Yeah.
And how about the next week?
And Fu, you have any idea? Because I have no idea. Win just asked me to come today with the class. I didn't expect that I could come here. Okay, now let me ask Win again. Okay, I will tell you next time.
And then can I cut you? But probably we done the oral now. The next step can we do written report?
Good, very good.
You prepare the case. You writing the case back to the doctor who sent the patient to you. What we normally do, I'm a specialist here. When the doctor send the patient to me, and I check, I do the treatment, I then send a report back to the doctor. So what you need to do, I'm going to assign a case when you all do pediatrics. So in the long-term Vietnam, we would introduce a system where general practice, family doctor, and you are a specialist. So I'm going to send you the case, and you get that case, and you treating the doctor, that child, and you writing the report back to the other doctor. I'll send you the form now precisely and professionally you're writing. That's your level, next level, your specialist level now. You've got the level. It's hard. It's not easy. It took me many years to write the problem report back to general practice. About 1 page or half a page, but need to precise, including all your treatment and your diagnosis and your treatment and what the planning, what the follow-up and planning follow-up. What do you think?
How do you think? It's a quite challenge. Huh? Yeah, turn on the mic. Please? Yes.
Alton said that because it is so difficult. So we would like to do it again in the next week with other case, which Dr. Fu post on the group.
All right. So do you want to go keep going with one more session of oral presentation?
Yeah.
Okay, I think that's a good thing. You go back to learn, what we learned today. Next week, you use all your knowledge today, and you're improving. To make sure the presentation look more professional. I think they probably emphasize what we learned. That's a good thing. Writing a report is not easy at all. It's hard.
Yes, and normally we will prepare a slide for the presentation. So next week, I will ask everybody for the slide for their presentation, and on the webinar presentation, they will show slide accompanied with the oral presentation.
Oh, that's good. Yeah, you present your slide just like in the meeting. Your slide presentation, the case usually take about 5 to 10 minutes. So, but 5 minutes per time frame is good. Your more need to be precisely follow-up system. Don't jump over. When you do slide, I mean, you have chance. You're jumping from one to another. Yeah. Do the system, please.
Yeah, because you know there is some negative or the side we can't have enough time to explain, and it's on the slide only, and the listener will see on the slide and easier to follow the presentation.
Okay, good. That's good. Yeah, good.
Yeah.
Cho em nói tiếng Việt chút xíu để cho hiểu rõ cho chị Minh đó. Dạ, dạ hồi nãy giờ thì có một số cái không có rõ cái pronunciation với lại cái từ đó, thành ra là cái tốt nhất là vô Google mà cái đọc cái Google chị có thể chị bật cái tiếng lên á thì nó có thể nó đọc cho mình, xong mình đọc theo nó, thì cái đó là nó dễ nhất. Chứ nhiều khi mình đọc cái từ phiên âm của nó nhiều khi mình cũng không có rồi, nó không có hiểu rõ là cái phiên âm đó là nó có nghĩa âm như thế nào.
Audio.
Dạ, thành ra nó có cái audio thì nó đỡ hơn. Rồi em nghĩ
excuse me, xin lỗi bác sĩ Nhiều một chút xíu ha. Cái Google vô Google đó, mấy em vô cái Google Translate, cái Google Translate lúc nào nó cũng có phát âm, nhưng mà coi chừng nha, có những cái phát âm nó cũng bậy chứ không phải là có thể là khoảng chừng 5% là nó bậy á, chứ không phải là trúng đâu. Do nó không chắc á, thì là Dolan's Illustrated Dictionary to check lại nào nữa.
Cái dictionary thì nó tốt nhất. Dạ.
Cái đó là trúng nhất, nhưng mà nó không có phát âm cho mình không có nghe được, còn kia mình bắt chước được. Google Translate.
Có mấy cái app này nọ nó cũng có translate, nó cũng có đọc cho mình, thì cái đó nó cũng good. Rồi em đề nghị là làm một số mấy cái case nào mà về consultation cho mấy cái specialist, mình có cái specialist cardiologist ở đây nè, rồi mấy anh ở đây nữa, thành ra là em nghĩ làm cái presentation rồi có cái consultation luôn, thì nó hơi chuyên qua chút xíu nữa thì nó đỡ. Hoặc là có thể sau đó thì có thể cardiologist có thể cho, hoặc là mấy anh có thể cho luôn cái giống như là đang nói chuyện luôn, thì nó làm giống như là oral presentation case luôn.
Không, mình nghĩ mấy cái chuyên khoa chắc nói chuyện cho mấy em thôi, chứ mà presentation cho cái specialist là ghê lắm. Mình chỉ cầu cho cái presentation cho những cái bác sĩ bình thường thôi, mà cho nó ngon á là mình mừng hết lớn rồi. Chứ mà qua specialist nữa là thì thôi chết, chỉ cho để specialist trình bày thì chỉ có trúng rồi.
Cái specialist nó dễ hơn bình thường, tại nó chỉ có focus một cái organ thôi.
Okay.
Dạ, thì chắc nó cũng dễ hơn, không có sao đâu.
Tức là không là dễ hơn cho những người specialist, nhưng mà không dễ cho cái nhóm học. Không dễ cho nhóm học.
Nhưng mà em nghĩ cái đó try cũng good, tại vì cái đó nó khớp hơn là trình bày một cái case bình thường.
Thì mà hôm vừa rồi thì cũng có ý định là sẽ chọn ra một vài cái để gọi là tư vấn chuyên gia đó. Tuy nhiên là em nghĩ là lần tới thì một vài bạn trong cái nhóm mà chuẩn bị đó, ví dụ như cái cây u gan, khối u bụng này nè, là thực tế bọn em cũng có cái gọi để hỏi chuyên gia, bởi vì ở đây á, là nó có 2 bước. Bọn em sẽ là hội chẩn ở trong khoa, xong là thống nhất sẽ làm một số cái xét nghiệm gì, xong rồi khi có kết quả xét nghiệm thì lúc đó sẽ hội chẩn bệnh viện, có nghĩa là mời hết tất cả các khoa liên quan tới, rồi xong rồi là có những trường hợp khó thì sẽ phải gọi tới những bệnh viện tuyến trên để nhờ các anh đó tư vấn là bọn em sẽ quyết định làm cái này cho bệnh nhân, thì theo ý anh như vậy là đã ok chưa? Đó, thì những cái ca khó là bọn em thực tế là bọn em làm như vậy.
Dạ, thì đó thì em nghĩ là làm một số cái case như vậy, present nó thử cái nó làm sao.
Như ý chị Như vậy đó, là cái khúc mình sẽ làm thêm một cái khúc sau nữa là mình gọi xin tư vấn bằng cái tóm tắt cái tình hình bệnh nhân dạy từ đầu tới cuối, và em thấy cũng ok.
Xin lỗi, có đây mình hỏi một chút hơi lạc đề chút xíu nhưng mà chỉ có bây giờ có cái cơ hội thôi. Ở Đà Nẵng á, cách bệnh viện Đà Nẵng á, có làm cái PICC line không?
PICC line là cái gì ạ?
Nói gì là không biết rồi. Đó là cái Central Venous Access.
Có chứ.
Như thế này, lý do thế này là tại vì trong VietMD á, là có anh Dustin Nguyễn á, ảnh có phụ trách về một cái về cái viện trợ cho Việt Nam, mà trong phần đó tôi đương xin để gửi một cái nhiều đợt để về để làm cái PICC line cho những bệnh nhân ung thư, mà người ta chỉ hỏi Hả? Có không?
Rồi, tại anh nói tiếng Anh đi em không biết. Chứ còn ở đây thì bọn em bệnh nhân ung thư bọn em vẫn làm. Đó là đường truyền trung đúng không ạ?
Không. Tiết lai là cái ống mà mình đặt ngay chỗ cái tai á, mà đi vô tim á, nó là cái giống như là cái đường tĩnh mạch trung ương á.
Viết lai đúng rồi, PICC.
PICC có không?
Dạ có.
Ok.
Cái đó thường quy cho hai đối tượng, một đó là đối tượng bệnh nhân ung thư và đối tượng thứ hai đó là đối tượng mà nuôi ăn tĩnh mạch kéo dài.
Ok rồi. Good. I got it. Ok, got it. Bây giờ sẽ như thế là Đà Nẵng không cần. Ok.
Ở Đà Nẵng có kim chích không?
Nhưng mà ý là bọn em vẫn vì cái đường truyền trung tâm này á, thì hiện tại á, là có một số á, là được chi trả nhưng mà một số không được chi trả á, là bọn em vẫn xin tài trợ. Nên anh có anh cứ cho Đà Nẵng cái gì cũng nhận hết á.
Ok. Rồi mình không quyết định cái đó được nhưng mà mình báo cáo cho họ.
Dạ, ý là bọn em nói về mặt kỹ thuật á, là bọn em có làm nhưng mà dụng cụ á, là đương nhiên là bọn em cứ cho càng nhiều càng tốt, là có lợi cho bệnh nhân. Bọn em khỏi phải đi xin chỗ này chỗ kia xin tiền để trả.
Ok. Nhưng mà tôi nghĩ thế mà bây giờ thì mình ví dụ như khuyến như cardiology, giống như mình set up một cái case về cardiac case thì khuyến có more specialized, thì khuyến có thể góp ý được cái case nó easier, thì cái đó đồng ý đúng rồi đó, giống như những người chuyên khoa vậy á. Còn tôi thì coi như là hầm lần thì biết chỗ nào chỗ nọ nó không có rõ lắm. Thì với lại cái hai tôi muốn nói các bạn là cái cách presentation dù sao đi nữa nó vẫn còn nhiều cái chỗ mà các bạn phải học lắm, tại vì nó còn không biết cái lối cái công việc làm Việt Nam nó nhanh quá hay gì đó, thì nó có những cái xúc ngắc. Như nếu mà các bạn nghĩ trong tương lai có hướng mà vươn xa lên nữa, đi ra xa, thì bây giờ bạn phải làm lại từ đầu. Các bạn phải làm một cái system, như hỏi bác sĩ Như học lại, còn bác sĩ Như thì thấy những cái cách mình học nó khác. Ví dụ phải system, nhưng em không có bỏ được qua mấy cái step này. Khi mình một cái không được vô system đó rồi mình present một cái ca mà lộn xộn vậy, you never come to pass exam. Nên đã cố gắng quay trở lại đi, bước lại một bước nữa để kỳ tuần tới tôi nghĩ hy vọng present với các bạn present cái case nó phải làm sao cho nó rõ ràng, nó clear, nó systematic. Dù đó mình cảm thấy mình vẫn là còn trẻ con, mình system, nhưng mà cái đó là how they're working, you know, otherwise chứ tùm lum hết đó. Khi mà giống như tôi lên special level mà tôi present một cái mà nó lộn xộn cái là coi lúc giống như mắc cỡ kinh khủng lắm. Tại sao? Nhưng mà mình xài cái template đó, mình xài nên không có gì bị trật đó, không ai dám đúng làm gì đó. Cố gắng quay lại làm cái template mà tôi gửi như cái gì đó, thì giữ cái đó làm vậy thôi, thì có trời nó không sai được đâu.
Nó khó hơn thành phố cũng không bắt được đâu đúng không?
Bắt đi, tập đi lại đi.
Okay. Anything else? Any suggestions? Any feedback? Anything before we close the class here?
Anh đi ngủ, còn mấy bà anh đi ăn.
Trời ơi, buồn ngủ quá trời rồi đó.
Thank you so much.
Okay. So see you next time, huh? Okay.
Bye.
Okay. Bye. Have a good. Okay. Good night. Okay.